This is where we left off yesterday. Um, so, clinical application of neuroscience. What are we studying neuroscience for as a physical therapist? Is we want to understand the effects of how various nervous system lesions, especially, will affect our treatment and affect the presentation of our patients. Also, as a doctoring profession, we have to do some basic differential diagnosis and know when to refer our patients and when we shouldn't be seeing them or when they would benefit from some other healthcare professional. Um, so, and it's in, you know, there's the stories are out there, and I've caught some people. I've caught a couple people in my outpatient days that had something other than your typical back pain. They had weakness and numbness and foot drop, and they were a younger female, and it was MS, and it wasn't sciatica or something like that. So, knowing signs and symptoms of upper motor neuron versus lower motor neuron lesions and how to test for those and those kind of things is really, really important. So, and just, if you understand the fundamentals of anatomy, neuroanatomy, neurophysiology, biomechanics, and all that kind of stuff, the best PTs are the ones that are really good at the basics and do the basics all the time, and do it the same way and are really good at it. So just having that foundational knowledge is the more I learn about this, just the more it's not all the bells and whistles. It's really just the fundamentals and knowing those really well. So um, let's talk about some broad categories. When you have a lesion, or a damage to the central nervous system, that can be kind of categorized in one of these three major categories, big type categories. Is a focal type lesion, which is a lesion that is in one distinct region of the nervous system, okay, and is contained within that one region. It's, so like a tumor or a stroke. Now, tumor can expand and grow, so that tumor is circumscribed, but symptoms can change and get worse. Sometimes strokes can get worse too, initially after the stroke, especially like a bleed. They call it a stroke in evolution, where you have the initial symptoms, but if you have an additional swelling, or sometimes there's some cells on the periphery of the stroke or a tumor or something that are semi-working, that can go either way depending on if you're able to resect the tumor or reduce the inflammation or stop the bleed in the stroke, that those cells can recover and refunction again, or they can get worse and die off. So that's, even though it's focal, the symptoms can still change a little bit. It's gonna cause very distinct symptoms related to the location within the nervous system that it's at. And then there's like multifocal lesions. Multifocal lesions would be like something like a metastasized tumor, where you have multiple lesions in the nervous system that can cause, that can be more challenging because it can cause symptoms that are more wide-ranging, more hard to pin down because you have these multifocal lesions. Also something like multiple sclerosis. So multiple sclerosis causes damage to the lining or the insulating myelin of the central nervous system, of the axons. The oligodendrocytes are the little cell that wraps around the around the axon in the central nervous system. It causes scarring and damage to that, which impairs action potential propagation and so forth. But they can be anywhere within the central nervous system. So you can have them in the brain, cerebellum, brainstem, or spinal cord. And some patients have a propensity to have them more in one area than another. Um, for example, Crystal, who I forgot to even tell you was going to be here yesterday, was an individual with MS I've been working with regularly, who has very severe cerebellar lesions. And so one of her primary deficits is ataxia, which is a very pronounced incoordination that is very characteristics of a cerebellar type lesion. So if you want to see that, if you come and watch me, we can do a few tests for that just to kind of show you what that looks like. But she also has a lesion that is affected, and I think she's got a lot of brainstem region lesions because she's also a lot of dysarthria, but it's also related to some cerebellum that controls your speech as well. But she has foot drop and pretty significant weakness on her right lower extremity. So she probably has a lesion of the cortical spinal tract also, and causing the weakness in her right leg. So that's probably happening in the brainstem or cerebrum. Could be in the spinal cord. And then diffuse lesions. So these are lesions that are more diffuse and widespread. They don't have these little spots, but they can kind of spread and cause, general degeneration or inflammation or infection of large regions of the nervous system. So like Alzheimer's disease causes global degeneration of the brain, and it tends to start more in the frontal poles and the temporal poles, the front part of your brain, and then as it progresses, it gets worse, and then it can cause even motor impairments and things like that, but it's generally more memory and cognitive, especially initially, and then it can lead to later degeneration of the entire nervous system. There's actually this brain right here has some atrophy. You can see the sulci are more pronounced on this brain than the brain over here. And there's another brain I just took out yesterday that has some shriveling of the frontal and temporal poles, and you can actually see that those frontal and temporal poles are more shriveled, and also the sulci are a little bit more enlarged on in those areas in the frontal cortex and lobe and the temporal lobes, the front parts of those. The back of the brain looks relatively normal because that degeneration was happening in there, and we don't know. I can't tell if it's Alzheimer's or not. There's lots of different types of dementias, but it could have been. And then things like a bacterial meningitis or encephalitis or something like that can cause widespread neurologic disorders. Oftentimes you have impaired consciousness with those if they're really bad enough. So that's going to be focal, multifocal, or diffuse types of nervous system lesions. There's primary etiologies for nervous system lesions that we can talk about. So, or categories of nervous system lesions. Trauma is one. So, trauma, head injury, bullet, knife, whatever, a motor vehicle accident, acceleration, deceleration injury. So, trauma. Okay. So, the actual trauma that causes direct insult to the neurons, as that the bullet passing through the brain, or when you hit the windshield and you get shearing and tearing of axons and ripping of the cell membrane. That's the trauma that causes direct injury and insult to the neurons themselves. Then you have vascular disorders. So vascular disorders are going to be like stroke is going to be your obviously biggest one. So that could be either you have bleeding into the brain, which if your blood vessel bleeds, the bleeding is a problem because, especially in the brain, it's a closed cavity, right? And so when you bleed into a closed cavity, pressure builds up. And that pressure then pushes on structures and then creates lack of blood supply to wide areas because you start building up pressure. And if that pressure exceeds what your blood pressure is, you can't get blood up into that area. But also, remember, if you tear open a vessel, especially a large artery, downstream, those cells aren't getting the blood that was supposed to get to them. It doesn't do it any good when that blood is out in the environment. You got to get to the blood, to the to the vessels, to the capillaries, and all that kind of stuff to get actual oxygen distribution. So bleeds are sometimes worse than an ischemic stroke. An ischemic stroke is where you just have a blockage, but no bleed. There's a blockage downstream, but with a blockage, at least you don't have pressure building up in that system as well. So vascular disorders can be a bleed, or it can be just purely a blockage or an ischemic type stroke, we call that. Inflammation, okay, and any kind of encephalitis or inflammation, or especially inflammation of the meninges, they can get inflamed, like a meningitis can cause that. Degenerative would be any kind of, like Alzheimer's, Parkinson's would be degenerative in nature. MS could be considered degenerative in nature because they're progressive in a lot of cases. Next is neoplasms, which would be tumors, okay, cancer. Immunologic disorders. Sometimes, like MS, crosses over that line. It's degenerative, but it's also it's an autoimmune type response is what mediates that. So it kind of can fit into those two categories, but some type of an immune response. And then toxic or metabolic. So metabolic disorders, or if you have lack of oxygen, hypoxia, that causes a metabolic disorder if you don't get enough oxygen to your brain. different types of like heavy metals can be toxic. Carbon monoxide poisoning would be a toxic damage to your nervous system. So those are the types of things we're talking about there. We'll get into all these later when we get to more clinical disorders. When you're doing a neurologic exam, and you don't have a good history, like maybe they haven't gone to a neurologist or your physician, you're taking this history, these are some of the things you want to be thinking about. One is speed of onset. Okay, and when we do the clinical cases, we'll reinforce these, so we'll ask those questions, like if we're trying to come up with a diagnosis, I'll help I have a little check sheet you can do to kind of cue you on what things to be looking for. So speed of onset is really important. Did it happen instantly? Like, boom, I got this massive headache and now my left side doesn't work, That's pretty telling right there that it was an instant kind of onset. Is like more of a subacute onset, like you notice your symptoms happening and they got progressively worse with maybe over with a few days to a week worth of time, okay? But then they stabilize, but they're either getting better now or they're staying the same, but it took about a few days to a week to get there. Or, hey, this is something I've noticed for months and years going on. I remember having symptoms like this, 10 years ago, those kind of things. But now they are reappearing again and that kind of stuff. So all those things will help you start to maybe categorize or at least give you some clues of what you're talking about. So the pattern of progression, when it does happen, was it a slow, fast type of progression? Was it relapsing, remitting, where the symptoms wax and wane, like the symptoms go up, they get better, then they get worse, those kind of things. Mental status will tell you some things too. Is it affecting them cognitively? And then we're going to do an examination, and we're going to test specific motor, sensory, and mental function. Believe it or not, the most common symptom of a neurologic disorder is motor deficit. Is the most common symptom of a neurologic disorder. And I think sensory is second, and then mental might be even third in that order, but don't quote me on that. But I know that some type of motor dysfunction, weakness, spasticity, fasciculations, spasms, those kind of things are the most common. And that's why we work with the motor system, and patients will come to us with problems that affect their motor system, and could be a nervous system lesion. Then you diagnose, determining specific cause of symptoms. We're not, as a physical therapist, we don't diagnose the disease or the pathology. We diagnose the movement disorder, and we'll talk about when we get to clinical neuro in the fall. There's actually a movement by the Academy of Neurologic Physical Therapy to kind of push forward with this, what we call movement system diagnosis. So taking any patient, whether they're stroke, Parkinson's, MS, that's their medical diagnosis, but then classifying them according to a movement system diagnosis, because I can do very similar treatments with somebody who has a brain injury and somebody who has a stroke who has what we call a fractionated movement disorder deficit. They move in synergistic motions, they have some weakness, but they can't isolate movement. I would do very similar treatments for that person, whether they have a stroke or a brain injury, because they have a movement fractionation deficit. And that's, as a physical therapist, that helps me guide my treatment more than knowing they have a stroke or a brain injury. Knowing what their movement disorder is what's going to help me say, oh, the research says that in order to improve isolated movement, I need to do this type of exercises or training for whether they have Parkinson's, MS, stroke, if they have this classification of movement disorder. So, but if you may have a clue that when you see this patient, maybe you were sent this patient to treat, and you had a certain medical diagnosis that they were sent to you with, and you're going, wait, symptoms are not matching up with that typical medical diagnosis. I need to send them back to their physician. And typically, you got to be careful about I'm usually not telling this patient what I think they have from a medical diagnosis. I may just say something like, I'm seeing some things or signs and symptoms that don't match your current diagnosis from your doctor. So before I continue treatment, I think it'd be good to have you check back in with your doctor, because I'm just seeing some things that don't match with the diagnosis that you initially provided me. And then you get on the phone or you talk to their PA or whatever and say, hey, I noticed that your patient who had low back pain, when I did a Babinski reflex, they had a positive Babinski reflex and their reflexes are high, like they're hyperactive. That's not matching with that's an upper motor neuron problem. That's not matching with a back pain referral to the leg, where I would typically expect lower reflexes and no Babinski reflex present. So those are the things. You're just going to give. You're not saying to the doctor, "I suspect they have MS," versus this. You just tell them the symptoms you're seeing, the signs you're seeing that don't match the current diagnosis. So. This is just kind of orient you to this little schematic diagram that Crossman book uses. And so they have these little boxes that you'll see occasionally pop up in the chapters that are related to certain disorders and so forth. And so here's an example. So they use this schematic. So they're showing you a representation of the nervous system. So on your left here, this is a schematic of the normal nervous system, okay? So you have this nice healthy looking tissue that's got a nice white matter and gray matter on it. This is the basal ganglia. These are the cerebral hemispheres here, okay? These are the ventricles. This is the cerebellum on each side. Here's your brainstem, okay? Midbrain, pons, and medulla. And your spinal cord. Then they show motor in red going to a muscle. This is the cervical area. This is upper body, okay? Then they show another motor neuron going to a muscle somewhere in the lower body, okay? And then the blue here is a sensory neuron, okay? That's got a receptor out in the periphery. This is that little cell body in the dorsal root ganglion out there. That's a sensory neuron. So they use that schematic throughout the book to show how certain disorders cause problems with those various parts of the nervous system. And so here you'll see this is a representation of neurodegenerative disorders. And so what you'll see here is, notice they've colored the entire thing in yellow. That means that neurodegenerative disorders can affect any part of the nervous system. That's all they're showing, is they're highlighting that everything in yellow there is showing that any part of the nervous system could be affected by a neurodegenerative disorder. But then you'll see, then they have some arrows and lines pointing to specific regions. So like you'll see lobar atrophy, that affects the cerebrum. Alzheimer's disease also affects the cerebrum. Huntington's disease here affects the basal ganglia. Actually, this, and more specifically, this part of the basal ganglia, putamen and caudate. And then Parkinson's disease. The Parkinson's disease affects the midbrain, a little area called the substantia nigra in the midbrain. Cerebellar ataxia. There's a cerebellar degeneration happens in the cerebellum. Motor neuron disease, which is amyotrophic lateral sclerosis, ALS, can affect the motor neurons. Okay. Hereditary spastic paraparesis can affect the spinal cord. Okay, and the pathways in the spinal cord. So you can quickly see really quickly what disorders are common and what parts of the nervous system they're affecting. Okay, so that's one of the schematics you'll see consistently in that Crossman book, and it's a nice way to take a quick look and see where in the nervous system and so when you get to the vascular system, they'll have a schematic for stroke, and it might show where a middle cerebral artery stroke is and where a whatever stroke is, or an aneurysm, and point to you where the most common region of that nervous system is involved with that, and those kind of things. Then you'll also see typically a little picture thing like this, so a schematic picture representation of the human body, and it's divided into 4 categories. So they have cranial nerves and motor system, reflexes, sensation, and coordination across the top. This is representative of what a normal person's function is in those 4 categories. So if they show the representation of the person like this, where there's no mark on their body, there's nothing outlined, nothing, that means that's totally normal. This is a normal functioning cranial nerve and motor system, okay? If they show these 1 pluses, like that, even though we know that typically a 2 plus is the normal, but if they just show a plus at each joint, major joint, that's biceps, triceps, ankle, knee, reflexes. That means normal, okay? If they show a little blue arrow down going, this is reflexes, that is a normal Babinski reflex. We didn't do Babinski reflex. That's where, have you ever had this done, where you scrape the bottom of your foot with a tuning fork or their thumbnail? And adults, their normal response is for the big toe and the little toes to go down a little bit into that. An abnormal response for an adult is for the big toe to go up and the other toes to flare out like this. The big toe extends and the other toes kind of flare out. That's an abnormal response for an adult, or anybody over the age of 5 years old or so, 3 years old. As your central nervous system myelinates, that goes away. That Babinski response. Once it's fully myelinated, or myelinated enough, it goes away. So it fades out but once you're over the age of 3 to 5, you don't have a Babinski. It should be downgoing. That's what the arrows are down. That's showing a downgoing Babinski reflex. Okay, and then here's sensation. There's nothing on the body highlighted or colored or anything like that. So that means normal sensation. And then coordination is just showing that here's these nice straight arrows and straight arrow for the legs. That means that if you ask them to move their arms, they move in a nice, smooth, coordinated fashion. Okay. And then your key to problems with these things is down here, okay? And so for each of these categories, when we start to look at, and I'll show you a picture here of a person with deficits, so for the motor system, there's a key here. If they color it, and is that greenish color or something like that? That seafoam, nice. You're going to do good. I saw you're engaged. Wow, so that's good. Learn those colors. You're going to paint that that accent wall in your house when you get muscle weakness and wasting, muscular fatigue if it's just outlined with this, where it's not muscle weakness and wasting, but they fatigue out. So it's not profound weakness; it's more muscular. If it's circled in red, it's a spastic weakness. The muscle's weak, but it's also spastic. I mean, it's where they move in this synergistic kind of patterns like this. And then also incontinence. So if they put a little bladder that looks all stretched out like that, it's supposed to be a bladder, I think. That looks like it's stretched out. It's just they're incontinent, which is part of your motor system. Your motor system has to contract those sphincters. And then we have a similar thing for if they have a negative, that means they have absent tendon reflexes or lower tendon reflexes. If they have 3 pluses, that means they're hyperactive reflexes. And then if you have an arrow going up, that's a extensor plantar response. The plantar response is also the Babinski reflex. That's the scraping of the plantar surface of your foot. And then if you outline the body with, or what color is that, Caleb? What magenta. I don't know if I go with that or not. I'm colorblind though, so I have to keep a headlamp next to my my bed, because when I get up in the morning, I have to shine it in my sock drawer with a really bright light so I can tell black versus navy and all that kind of stuff. So I've been caught before with different color socks and shoes. I'd buy, I'm a type of guy hey, that's a good shoe. I might as well buy black, brown, all the colors that are available. It fits, it works. But then sometimes I'll wear the black and brown shoe the same day. So look for those things. And then coordinated movement, you'll see if it shows this little squiggly line, that means it's uncoordinated movement. That's ataxic type movement, usually indicative of more of a cerebellar problem. And so here is the whole thing for somebody with a stroke. So in one shot, you can look at all the problems that a person with a stroke has. So starting over here, here's that little rough schematic of the entire nervous system. And they're showing you a lesion right there. That's a lesion in the cerebrum on the left side. It's a left-sided lesion. That's actually affecting what's called the internal capsule. That's some white matter. Those are axons that are running down from your cerebral cortex through that area to go down. And you'll notice that now they have a left-sided lesion and they have right-sided spastic weakness because it's outlined in red. And they even show the arm like this, which is a common posture for somebody with spastic weakness. Brain injury can do this, stroke can do this, where they tend to hold their arm possibly a little bit flex position. It's not always that extreme, but that's spastic weakness. And they also show it's common for the leg to be more extended and more tone in the muscles that extend the leg. Even though it's weak, they tend to have a bias towards their leg kind of wanting to stay straight. Like when they walk, they have a hard time bending their leg, and they'll walk with it. And that's why they're showing the toe pointing down and the leg kind of extended like that. So that's very telling that that's what you might see from a standpoint of the motor system. Spastic weakness with these stereotypical movement patterns. And then you'll notice that they have hyperactive reflexes at the wrist, elbow, tricep, knee, and ankle. So reflexes are all higher on that side. That's because it's spastic. It's upper motor neuron, damage to the central nervous system, motor system will cause hyperactive reflexes typically, okay? And you'll notice the other side's pretty normal. They may have even an absent reflex for the abdominal reflex, but don't worry about that. Because that's one you actually you scrape up the side of the abdominals and you watch their umbilicus should go towards that side that you scrape up. It's not like a tendon reflex, it's just a superficial reflex. But if they have lack of sensation on that side, then they won't feel it as much and the umbilicus won't deviate. But I never test an abdominal reflex. It just doesn't functionally mean a lot to us. So, and then here they're showing there's the possibility that you could have impaired sensation on that entire right side of the body, okay? It would really depend on exactly the extent of that lesion and where exactly it's located. It may not be the whole body, but it could. You know, it could affect that whole side of the body on that side. So that's what they're showing there. And they're showing that when they do try to move, because they're spastic, that their coordination will probably look somewhat impaired. So the upper extremity, when they move it, it'll go something like this, and the leg will do something like this, and so it'll look a little bit uncoordinated. So that is showing you the deficits associated with the stroke. So sometimes it's easier to look at that than to read a list of all the symptoms and signs, or do a little bit of both. So I just want, that's why I love that Crossman book, because it really is powerful to be able to quickly just look at that and go, oh, there's the lesion, here's all the symptoms, you know, where's the lesion at, where are the symptoms, which side, is it both sides, one side, you know, those kind of things. So that's all I wanted to point out. So if you have questions as you go through the book or have anything, let me know. Woohoo! All right, let's do this. We're just going to let's take a 5-minute, 7-minute break here. Come back. So what we'll do is you'll like get in groups of, most of it will be groups of 6, maybe one group of 5. Let me pause this. All right. Oh, I was also going to mention, when we're talking about structures, in the lab manual, you'll notice when you look at the picture, then you have the little key on the back. Some things I've crossed off. Those are things you don't need to know. So if I've crossed it off, you don't need to know that. You know, there's things on there that I haven't crossed off that you may not ever get asked about, but they're structures that I think are somewhat relevant. I will pretty much talk about any structure you need to know, say it, and have it up on a slide or something, so if that helps you. All right, so let's go through this. So the first thing that you can't see, because you only have one half of the brain, you'd have to have the two halves of the brain to have the cerebral longitudinal fissure. That's the one right down the center, is the cerebral longitudinal fissure. So that's what I cut through. I took my nice cake, it looks like a cake knife in there, microtome, and you just, it's not that sharp actually, you just kind of, a little firm pressure, and you just slide it, and you don't saw it, you just kind of place it and you just go whoop and slide it through. So then the next major thing we want to find is the lateral sylvian fissure. So that's, let me go with yellow on this color here. So that's this thing right here, the lateral fissure or sylvian fissure or the lateral sylvian fissure. And that is the one that if you want to try, now there's two of these specimens that are kind of mushy. They're kind of a little more slimy and mushy because the preservative didn't get into the brain very well. But you can carefully or gently try to pull it apart a little bit and see if you see that insular lobe down in there. And you may have, some of you may have some blood vessels that are coming out of there. That's actually where the middle cerebral artery comes out of that lateral sylvian fissure to go to supply the lateral surface of the cerebrum. So most of them have been, I've ripped it out, but you may see some vessels down in there too that are coming out. Hopefully everybody got the lateral sylvian. Okay. The next one is we need to identify as the central sulcus. Every brain is slightly different. So this particular specimen, this is the central sulcus right here. Occasionally you might have to jump a gyrus or something like that. Like the sulcus may be interrupted, but this one is a pretty clean one. Occasionally there's a little jump you have to make over that. One of the clues to know if you're in the central sulcus is follow this all the way up to the top and then follow it over to the medial surface. And generally what this little thing does is it dives, it goes over the top and dives posteriorly just a little bit. And I'll show you on this side. Here it is right here. It's diving, this is the central sulcus coming up and it's diving a little bit posterior as it comes over the top. The precentral and postcentral sulcuses don't typically go over onto the medial surface at all. They stop before you get to the top or right at the top of the ridge there. The central sulcus goes all the way over, then dives back a little bit. Raise your hand if you don't think you have your central sulcus or want me to come verify for you. Excuse me.
So we thought that it was this one right here.
It is that one. Yours doesn't do. Yours goes a little bit forward, then backwards. So the occasional one will go forward versus backwards. Yep, that's it. Yep. All right. Yeah. Yes, that's the one. Yep. So once you've got your central sulcus and your lateral sylvian fissure, you kind of join those and you've kind of made some divisions here, which are nice. But those are some of our reference lines to go look for other things. So the first thing we're going to look for is the precentral sulcus, which in this case is this region right here. And you'll notice that I have to jump over some gyri and kind of extend this line down. So this is the precentral sulcus. It's in front of the central sulcus, so it's called the precentral sulcus. And then we jump a sulcus back from the central sulcus, and this is a weird postcentral sulcus here. This one is not, this is a little atypical, but you notice I had to jump this gyrus right here and kind of connect the dots. That is the postcentral sulcus for this particular brain. So see if you can find your pre and postcentral sulci. Raise your hand if you don't think you have them. Should be the next most vertically aligned sulcus, either before or after that central sulcus. Once you got those, the next thing we're going to identify is called the preoccipital notch. So it's this little notch that's just before the occipital lobe, and it helps define where the occipital lobe starts. So here's your cerebellum right here. There's a little notch right there. It's just a little indentation notch right there that is about 3/4 of the way back across the top of the cerebellum. Some brains it's a little more pronounced than others. I'm gonna erase my little drawing there just so you can see it's this little notch, is a little sulcus right there. That's the preoccipital notch. Sometimes you almost have to imagine it a little bit. Yep,
So
that's
the
it.
farther back one?
It's that one, yep, right there. Raise your hand if you don't think you have it or feel pretty good about it. Preoccipital notch.
I picked a mushy brain.
Yeah, and it's gotten, it would be right there.
Okay.
Yeah, it should be. It would normally be there if it wasn't, that brain wasn't, yeah, gross and torn up. So. All righty, good. Now let's talk about some gyrus, the gyri that are important that we're going to talk about here. The first one, let me change the color just a little bit to something different. Let's go with green, is the precentral gyrus. I can't see green. That doesn't show up very well. Orange? Maybe a little bit. So between the precentral sulcus and the central sulcus, that defines the borders of your precentral gyrus. Does anybody know what the precentral gyrus, its primary function is? Remember way back from undergrad? Any? Motor. It's your primary motor strip. That's for sending signals to create discrete fractionated movement of your limbs when you want to send a signal to do voluntary motor activity with your tongue and face kind of down here, your hand in here, your torso and arm here. Then you go over the medial surface, and your leg, it's like your knee is hanging over, and your foot is down on the medial surface of the cerebrum for the motor strip, because the motor strip continues all the way over on the medial surface. Okay. And then the post-central gyrus is this area between the post-central sulcus and the the central sulcus. And that representation of your body somatotopically across the top, that's called the homunculus. Okay, and the homunculus for the sensory system is very similar. It's almost the exact same. So a very similar representation of face and so forth down here, and then it wraps up over the top with the leg. Okay. Let's do superior temporal gyrus. Let me just show you something here too. So there's this is called the superior temporal sulcus right here. There's also an inferior temporal sulcus in here, but this is the superior temporal gyrus right there. The primary auditory cortex is located in there, right about here. This is where your primary auditory cortex, that's where sound initially lands there. It's processed in other areas. You make sense of it in other areas, but the initial loudness and frequency of the sound are appreciated right there at that primary auditory area before it's sent to your secondary auditory areas that says, oh, that's somebody talking, or that's a bell, or that's a car drive, before you recognize what it is. But the initial signals are sent to the primary auditory area that's right there, kind of right that sylvian fissure, end of that sylvian fissure, right at the top of the superior temporal gyrus. Now let me just erase a bunch of this. And we're going to show you the lobes, okay? So we have our lateral, let me go back to yellow. Lateral Sylvian fissure, central sulcus, preoccipital notch. And if we do this, if we go, and then I'm going to look at the medial surface here real quick. This is called the parietal occipital sulcus. There's a very defined sulcus back here, and I'm just going to kind of go over to the lateral surface here, and it's going to come up right about here. And if I connect a line from my preoccipital notch to that parietal occipital sulcus where it comes up from the medial side, that defines my occipital lobe. Then if I just take this line and just extend it like that, now I've defined all my things here. I've got parietal, temporal, and frontal lobes, and then the occipital lobe back here. That's kind of how you roughly define the borders of your different lobes by doing that. All right. Now we get to flip the brain over. It's exciting. Lots of stuff over here. A little more interesting. A little more intimidating at times, but not too bad. So first of all, let's talk about the corpus callosum. Really obvious, easy to find, nice big white matter structure. It's a commissural fiber. Connects basically frontal and your temporal lobes, and some of your gets close to the occipital lobe, but connects those most of your two hemispheres together. Okay, there's lots of communication between the two sides, which you don't need a lot of that communication, but it is important for certain things. But there is some subdivisions of this corpus callosum. The first one is the rostrum. Remember, rostrum is beak towards the front. This little region right here is the beak or the rostrum of the corpus callosum. That little tip that curls back underneath is the rostrum. Then we have what's called the genu, and genu is the knee or the bend in the corpus callosum. So it's really kind of this structure right in here. That's the genu of the corpus callosum. Then this kind of more straight region here is called the trunk. Okay, so trunk. Then this kind of rounder bulbous structure at the back is called the splenium of the corpus callosum. Okay, so if in the one of the lab practical, which would be pictures up here, if I highlight something like this and I say identify the structure, be specific, you know, so you would say splenium of the corpus callosum. Okay. Now the next thing is the diencephalon, which is primarily the thalamus and hypothalamus. Your Crossman book also considers the epithalamus and the subthalamus as part of the diencephalon, but most people just consider that this. So we're gonna circle the diencephalon right here. So that's the diencephalon. That's hypothalamus and thalamus together. You can kind of see how there's a little bit of a definition there. If I just kind of follow, there's a little bit of a definition there. So this round egg-like area structure is the thalamus. Some of your brains, you'll notice a little protrusion right here in the middle of that thalamus. That little protrusion or bump is the intrathalamic adhesion. There's a little connecting stalk in most brains. Not all brains have an intrathalamic adhesion. There's a small percentage that don't. And it doesn't seem to, I mean, you wouldn't know, the person doesn't have deficits because of that. But most of us have a little connecting stalk between our thalamuses that is going right in between the third ventricle there, bridging that third ventricle. So that's the intrathalamic adhesion. And then this little region right here below, this is all the hypothalamus. But the complete structure together is your diencephalon. Some of you then might notice some of your brains just might have gotten torn off or poked on too many times, and you may not be able to see it very well. There's a little white structure right here. So here's your interthalamic adhesion and your thalamus. If you come straight forward and a little bit down, there's a little white matter tract, another commissural fiber called the anterior white commissure or the anterior commissure. Sometimes it's the AWC, anterior white commissure, or just the anterior commissure. And that actually goes, it connects the temporal lobe on one side and it crosses over to the temporal lobe on the other side. So it's a little connecting white matter tract between the two temporal lobes. So that's the anterior white commissure right there. Another thing down here which I don't have listed is some of you will have your mammillary body right down here, which is, remember, that's part of your midbrain structures. Because your midbrain is actually this whole region right here. This is all midbrain. This whole region and here is midbrain, including those mammillary bodies. So this, I'll show you where it gets a little confusing in here, is because you've got your interthalamic adhesion, your anterior white commissure, your mammillary body, and then right here you have your optic chiasm. That's the crossing point for part of your visual pathways. Part of your vision crosses at that optic chiasm. And this is the optic nerves. Some of you will have an optic nerve. Some of you may not have the best optic nerve still hanging on there. So, you know, here's your hypothalamus. So then the optic chiasm is right below your hypothalamus, and then the optic nerve should be coming off of that. Okay. Here's the parieto-occipital sulcus. This is a pretty obvious sulcus you should be able to find right there. That's that defines the between your occipital lobe and your parietal lobe on the medial surface of the cerebrum. This area here, this is called the calcarine sulcus here. There's a sulcus right here called the calcarine sulcus. And that defines two different gyruses. This is the cuneus. And down here, this is the lingual gyrus down below. And it's lingual as tongue, kind of like tongue-like, and this, if you kind of look at that, it almost looks like a tongue. You know, you can imagine it as being a tongue, a lingual gyrus. Cuneus is kind of a cuneiform nature-looking structure, cuneiform, so the cuneus and the lingual gyrus. Your primary visual area, where your vision first goes in your brain, so your vision has a few stops. You know, it actually goes in, it goes crosses the optic chiasm. Some of that goes to your brainstem, the mediate reflexive-like looking. Then some of it goes to what's called the lateral geniculate nucleus, and then it goes optic radiations back to the primary visual areas, which are right on the edges, top and bottom edges of this calcarine sulcus, right at the bottom of the cuneus and the top of the lingual gyrus. This is where your primary visual cortices are. And your vision comes in flipped and upside down, basically, you know, when it comes in there. So like the bottom half of your visual field on the left side is going to this top part, or this, you know, upper region of the visual cortices on the right side. And then the upper half of your visual field on the left side is going to this lower part of the visual primary visual cortices on the right side. So I don't know why it was designed that way, just to make it confusing for PT students. Not yet. Not till the visual and vestibular lecture. So not for yet. Just know that just pointing out some things and letting you hear it multiple times. But good to check that. There's a region here. There's a structure here. This is called the precuneus. It's just a big part of this is part of the parietal lobe. I don't have it listed here, but just in case you read it or see something saying precuneus, because it's before the cuneus. It's before the cuneus back here, so it's the precuneus area. There's kind of a defined by this gyrus here in this area, precuneus. Next is the cingulate gyrus and sulcus. The cingulate sulcus, it's C-shaped. Cingulate, C, so that's the cingulate sulcus that wraps all the way around that inner surface, C-shaped. And then just below that, this whole region here is the cingulate gyrus, also C-shaped in nature. Then there's a sulcus right here, just above the corpus callosum. Oops. That's called the callosal sulcus. It's the callosal sulcus. Is the sulcus right above the corpus callosum. The cingulate gyrus is part of your limbic system. Limbic system has to do with your body's response to emotions. It has connections with all regions of your nervous system, including your autonomic nervous system and responses to stress and emotional responses that are autonomic in nature, your flushing of your face, your butterflies in your stomach, those kind of things, but also how you respond emotionally to events and those kind of things. So the cingulate gyrus has some role in those as part of your limbic system. We showed you the optic chiasm right here and the optic nerve. Most of you won't have it. You might see a little tag end of something right here dropping off, a little tiny thing that's not the optic nerve. It's called the infundibulum. Their pituitary gland is right here. Pituitary gland you can't get the pituitary gland out with the brain because it's sitting in your cranium. It's in this little thing called the sella turcica, and it's got a little membrane over the top of it. And so when we go to pull the brain out, we always just have to break that infundibulum. You can't by the time you pull the brain back enough to try to tease out the sella turcica, you've already broken the infundibulum, the little connecting stock that connects your hypothalamus to your pituitary gland. Remember, they're very connected because they both play a role in autonomic nervous system regulation and homeostasis. There's your hypothalamus, then it's connected to the pituitary gland via the infundibulum. Some of you, so here's your corpus callosum. Some of your brains will also have what looks like a little mini corpus callosum right down here. That's a white matter structure. It's called a fornix, but it is a white matter system and connections within your limbic system. It's a limbic system structure, white matter for the limbic system, likely connecting one side of the limbic system to the other. So this is called the fornix. Some of you, that fornix has been ripped out. That often gets ripped out when we take away, so there's a membrane right here that is actually over the so your lateral ventricle on each side, there's a membrane that separates it from the other side of your other lateral ventricle and from that third ventricle in the middle of your brain. It's called the septum pellucidum. Don't have to know that, but it's just this little But usually when we tear this away and open up so you can see into that big lateral ventricle, sometimes this fornix gets ripped out of there. Some of you I have left, the fornix is still there, and I've just kind of flapped back that septum pellucidum. You can just kind of like pull it out of the way and kind of see in there. I saw that a fair number of the brains. So if you take this, if you're looking into the lateral ventricle here, the cavity there, is you might see right on the floor of it right here, there's a little granular substance that might almost look like a little like caviar or fish eggs or something, but a little even smaller than that, laying right here on the floor of the lateral ventricle. That's some choroid plexus. It's a little pinkish in color, or gray. It's like a grayish pink maybe in color. You might have to dig around for it. Some of yours maybe don't have much of it left, but there's usually it's in that lateral ventricle. You might see a little gray, pinkish, little granular looking stuff in there, and down on that floor of that. If you have a fornix, there's a hole right here, and if you take your probe and you stick your probe up through this little hole, and behind the fornix you'll see your probe come up in here inside of the lateral ventricle. That's the intraventricular foramen. That's how cerebrospinal fluid gets out of your lateral ventricle and into your third ventricle on each side. That's the hole that it goes through to get there. So that's the intraventricular foramen. Let's look at the brainstem here. So remember, I'm going to kind of outline that whole region right there is your midbrain. Here's the mammillary bodies up front, hanging off the front of that midbrain. This is looking into your interpeduncular fossa right there. That's what we're looking into there. This region in here, we're in a sagittal section, right? That's referred to as the tegmentum of the midbrain. It's kind of like the meaty layer of the brain, and the tegmentum runs through the entire brainstem, but that's called the tegmentum of the midbrain. That meaty middle of the it's a meaty layer of the midbrain here, and then this back here, here's your cerebral aqueduct right here, running through the middle of your midbrain. That's that cerebral aqueduct, the little pathway there. And right off the back here, this is the superior and inferior colliculus. So there's a bump there. That's the superior colliculus, and then there's another bump here. That's the inferior colliculus. So when we looked at the back of that brainstem, we saw those two bumps on top, two bumps on bottom. If you have both of them, they're called the corpora quadrigemina. But right now we're only looking at half of a brain and half of a brain. So we're only looking at this would be the right, inferior and superior colliculus we're seeing there. And you see how there's the cerebral aqueduct running here. When you look at it in this view, people often refer to this little area of the combination of the superior and inferior colliculus kind of sitting, they're effectively like sitting on top of the midbrain, even though they're part of the midbrain. They're called the tectum of the midbrain because they're the roof. It's like the tectum of the midbrain, which is the superior and inferior colliculus. When you look at it in a sagittal view, they'll call that the tectum of the midbrain. It acts like a little roof over the midbrain. And then we have our pons, this region here. This part of the pons is this is the tegmentum of the pons, that meaty middle of the pons. The front part here, this is all the basilar pons, that front part. And that's where, especially in a sagittal section, you're going to be looking at basilar versus tegmentum, of the pons. Easier to appreciate. And then down here we have medulla. And the medulla also has a tegmentum kind of here in the middle. Then the pyramids are up in front here. But then you have the tegmentum just behind kind of where the pyramids are, that front part of the. So when we get to the brainstem, you're going to just this whole region here, this kind of middle region of the brainstem is called the tegmentum of the brainstem. And there's tons of stuff in there, lots of little nuclei and cranial nerve nuclei and respiratory centers and pneumotaxic centers and, so yeah, lots of stuff is in the tegmentum of the midbrain, believe it or not. Crazy how much stuff is packed in there. Let's see here. So, the motor tracks run down through this front part of the brainstem. They're coming down from the cerebral cortex, from whatever region, motor tracks, and they run down the front part of your brainstem mostly. So the front part of your brainstem is designated more to motor system. More in general, the back part, not always, but the back part is more sensory, coming up the back part of your brainstem. Then in the middle, all kinds of other stuff. Cranial nerve nuclei and other kinds of nuclei that send axons up into the cerebrum to regulate dopamine and different things like that. And so you kind of have two major routes, one going, motor going in the front, sensory coming up the back, with a bunch of stuff in the middle that does a lot of other things. Here is our cerebellum, sitting back there. And this is the anterior lobe here, and then the rest of that back there is posterior lobe. So make sure you feel like you're comfortable seeing where that division is of the anterior lobe. It's going to be that very first big sulci you come to as you move back along the top there to get the anterior lobe and then posterior lobe of the cerebellum. And then here's that fourth ventricle back here, all right? So that's the fourth ventricle. If we pull that cerebellum off, and if we're looking right down in here at the floor of the fourth ventricle, we're looking at a whole brainstem, that's the rhomboid fossa down there we'd be looking at when we're looking down at that, is the rhomboid fossa. You can kind of, in this one, there's an opening right here. This is where, and there's a little opening right in the middle, because we cut through the middle of your cerebellum. That's the foramina magendi, okay? And that's the one that's right there, and that's how you have your arachnoid layer that covers your entire nervous system here, and that's one of the ways that cerebrospinal fluid gets out and gets underneath that into that subarachnoid space to then surround your whole nervous system, is through that foramina magendi. Then there's the two lateral foramen. This is the median. It's also called the median aperture, the foramina magendi, or the median aperture, because it's in the middle, median, it's an aperture, it's an opening. And then you have the foramina luschka, or the lateral apertures. So luschka, lateral, magendi, median. Lateral apertures are the two holes on the outside, on the lateral side of the cerebellum, also kind of an underneath surface that also let the cerebral spinal fluid out. Got all that? You will. Don't need to know it all today, or even for the, you don't need to know anything of this for the quiz tomorrow or for Friday. I think that's enough for you guys today. Enough to chew on and digest, to give you a little bit of time to chill out before your next class.